Hello and welcome to another episode of Arthritis at Home. Today, I'm very pleased to be joined by ACE's president, Cheryl Koehn. I'm Kelly Lendvoy, and we're going to talk today about ACE's reporting from the American College of Rheumatology's annual meeting, ACR Convergence. This year was held in Washington, D.C. And as many of you, our audience, know, it's a gathering of arthritis healthcare providers, researchers, and patient advocates who all come together to share the newest discoveries and treatments for osteoarthritis and inflammatory arthritis. And this past week, ACE shared conference highlights so you, our members and subscribers, can stay up to date on the latest developments in care and treatment for people living with arthritis. Cheryl, welcome.
Hi, thank you, Kelly. Nice to be here again.
So this is certainly one of our research highlights of the year, along with the EULAR annual meeting that takes place every year in June in Europe. And at both of these conferences, ACE tries to follow the latest news, as I said. And certainly this past week, Cheryl, we heard a lot about new developments in treatment for arthritis. And one of the areas that we're starting to hear more information about is this whole area around what are called CAR-T therapies. And that stands for chimeric antigen receptor T cells. And that obviously already confuses me. Maybe you can enlighten me and the audience about what these therapies are. We know that they've revolutionized our cancer care. And we're, I guess, curious about their application in arthritis.
Sure. So I think for the purposes of just pure health education, we're not going to dive too deep into the basic science of it, first of all, because I'm not a basic scientist. We're health educators here at Arthritis Consumer Experts. But I will tell you this, that CAR-T, so if you encounter this in reading, this is to our audience, it's capital CAR and then a hyphen and a capital T, so CAR-T therapies have been used in cancer now for a number of years. And what we started to see at rheumatology meetings, like the American College of Rheumatology annual scientific meeting, Kelly, are, I want to say, autoimmune or autoimmune arthritis side effects. In other words, CAR-T therapy use in cancer treatment, while it is revolutionizing treatment, we are seeing sort of red flags occur as a result in people who have cancer and are receiving CAR-T therapy. Autoimmune diseases pop up, like rheumatoid arthritis, like other types of autoimmune arthritis. So why is that? Well, in the few presentations at this year's meeting, Dr. Ruella, as well as Dr. Capelli, who are experts in this field, talked about this. And what happens in CAR-T therapy is it releases cytokines in cancer patients. And cytokines are part of the reason that rheumatoid arthritis develops and is driven, right? So these cytokines are part of the disease process in rheumatoid arthritis. So what's good in one setting has become kind of inciting of disease in another. And so rheumatology, as a result, is being impacted. So oncologists and rheumatologists are now having to learn to speak each other's language, so to speak, in order to unravel the pros and cons of CAR-T therapy. So in the cancer setting, there's, in some people, development of autoimmune arthritis. But what rheumatology and scientists who work in the field, Kelly, are trying to figure out is how can we use CAR-T therapy to treat autoimmune forms of arthritis, understanding that they have this profound impact on releasing cytokines in the body. So, it's a real push me, pull me a sort of topic right now. And I think, we've seen early studies of CAR T therapy in severe forms of lupus. We've seen, infusion therapy of CAR T and seeing some benefit, but these are very small numbers, very early studies, Kelly. So no conclusion can be provided to our audience members. But it's just a super interesting area of therapy development to keep our eyes on. And so we're going to keep educating best we can as the science develops and to translate into reader-friendly language, into lay language or consumer-friendly language, that science. And I know we've written about it in one of our daily highlights, which we'll provide a link to at the end of our talk. So I hope that sort of teases you a bit with some of the early knowledge on CAR T in autoimmune disease.
Yeah, and those the two researchers who presented, they were talking about the application,
Yeah,
as you said, in lupus, but also systemic sclerosis and
yeah,
myositis.
yeah.
And
Two
once,
very, very often more rare forms of arthritis,
yeah,
not often thought of as arthritis, but treated within the rheumatology community
yeah.
by the
Uh,
rheumatology community.
so it's also, you mentioned lupus. It's also an interesting time to attend these conferences in the area of lupus because there's a growing field of research that we've been sharing over the past few years with our audience, Cheryl, and a corresponding development and launch of new medications to treat the disease. There was a special lecture this past week at the conference that addressed inequities in systemic lupus erythematosus, SLE, and how that is tied to geography, race, ethnicity, and socioeconomic status. I wonder if you could maybe share some of the findings of that special lecture that was delivered this past week.
Yeah, Kelly, it was great, first of all, to see this highlighted in the special lecture series at the meeting. So that's one. Two, I think Dr. Feldman shared some key points that actually we already knew, but they're important to hear from a very important stage. And so the conversation about inequity is being elevated to national stages. Importance is now being put upon it for change, demand for change. And that really is fundamental to taking on some of the systemic barriers on health inequities within the healthcare system. So individual rheumatologists can do specific things in their own clinics. But you also have to work at the healthcare system side as well and squeeze those two ends in the middle to achieve success and to achieve equity across the spectrum of healthcare for people who are dealing with lupus. Key among those is screening for social needs. We know there are social determinants of health. They're well published, well studied, been around for a long time. The application of those in clinic, such as through screening, has not been a regular part of a rheumatologist's daily practice. And so placing, kind of shining a light on that is a really key step at the individual clinic level. How are we dealing with understanding each patient as they walk through the door? But that doesn't solve the problem at the systemic level of the people who can't even get through the door. Okay? So a lot of people who face inequity every day in every aspect of their life, including healthcare, including care for their lupus, is going to be changed by community, and that is the larger rheumatology community. And I think that's the conversation that went on within the meeting that just took place over the last 4 days. So, really simple things, Kel, like transportation. So we don't think of transportation as healthcare, but if you
Right.
can't get to healthcare, you can't get healthcare. So it's really looking at fundamental things, transportation, medication access, usually through reimbursement, right? Once the FDA, in theory, approves something, or Health Canada approves something for sale in our countries, or the EMA, the European Medicines Agency, everyone has access to it, but only if you have money. Okay. So when we can't use the word access without reimbursement, I think, ahead of it. This is something you've heard me preach for a long, long time. We also have to understand the role that food insecurity and nutrition play in driving diseases like lupus. And if you don't have a secure food source or a quality food secure food source, you're not going to be doing nearly as well, even if you get the care, if you don't have proper nutrition. So, providers at the individual level, meaning rheumatologists, arthritis health professions like physiotherapists, occupational therapists, they have to do some serious self-reflection on what their implicit biases are, what their conscious and unconscious biases are. And we need to start working on those at an individual level. And I think our audience knows well, having talked about this a lot since 2019, that's really the focus of ACE's work, is to talk about it daily in our work, to write about it, to share it with our colleagues, and to reach out and try to hear from our members, followers, people who tune in to Arthritis at Home and any of our other programs.
And as a reminder to our audience, when we see health inequity, we see an opportunity for advocacy. And ACE currently in Canada is a co-chair of a lupus advocacy working group, and it represented by patient groups like ACE and Lupus Canada, as well as leading rheumatologists from across the country. One of those is Dr. Sasha Bernatsky, and we're going to have a link at the end of this episode. That's a recent conversation you had with Dr. Bernatsky about lupus, the disease, but also looking at barriers to reimbursement to lupus medications in Canada and some of these health disparities and inequities that you've described, and in the context of Canadian healthcare delivery. So our audience is going to have a chance to dive deeper if they want and take a look at that ACE resource at the end of this episode. Speaking of Canadian researchers, they shared the spotlight at ACR. And in this next highlight, we're going to look at one of them. This highlight is around performance-based tests, PBTs, and how they can enhance hip and knee osteoarthritis research and care. What are PBTs? Well, they measure functional abilities, what people with hip and knee OA can physically do compared to their perception of ability as assessed by more traditional patient-reported outcome measures, which are otherwise known as PROMs. At the conference, experts highlight the importance of PBTs in both research and clinical practice during a workshop. And what were some of the key findings from this workshop, Cheryl?
Well, I acronyms just
I know.
drive me, a bit around the bend a bit. So really simply put, performance-based tests, don't like the word tests, measures, basically counting what we do in very lay language. And they've been around actually for a long time, but I think we've really become tuned into them thanks to, and this is not a plug for this product, but for Apple and Fitbit and any of the devices that awakened us with step counting, right? It commercialized in a big way for health counting. And I mean, it's part of our everyday conversation now, Kelly, is, how many steps did you take today? But this idea of counting what we can do has been around for a long time, as Dr. Pellegrini highlighted in the sit to stand test, right? The sit to stand test has been around for a long, long time, and it's a really great functional measure you can do in your own home. And that is over 30 seconds. How many times can you stand up from a chair and sit back down from a regular height, normal height chair with your legs down at 90 degrees from the seat of the chair? How many times can you do that in 30 seconds? And if you work on that without the assistance of your hands and pushing up out of the chair, by the way, no cheating allowed, that is a measure of your function. And in actual fact, it's a great measure of fitness, function, ability, so function. It's just been around for ages. It requires a chair. And it's like standing up from your workstation, if you're at a seated workstation, every 20 minutes, right? These are things we can put a sticky note on our computer screen and do for ourselves every day. And that is really, that to me, that was one of the big key messages, or the key message from the presentation that Dr. Pellegrini gave, but also how Dr. Westby, our very close colleague, a key advisor to us, she was our reviewer and expert on our arthritis and exercise joint health education program. We can give a link to that at the end. She really reinforced how performance-based tests or measures are super useful in clinical practice. So not only are they good for us in our home, in our everyday life, they actually help clinicians on their side of the equation. They actually help assess how far someone has come, let's say, for example, in their physiotherapy program. What kinds of things do they need to build into your rehabilitation plan or your fitness plan to help you advance it towards your goals? It's also super motivational. That's another thing that we've learned from these step counting devices, whether it's your phone, whether it's something you wear on your wrist or clip onto your shoe. Like, people, you hear this stuff at, coffee. When you go for coffee with your friends, oh, I walked 10,000 steps yesterday, or wow, I'm doing that almost every day this week. I'm doing pretty, like, it's motivational, Kelly. And I think so some of this science that's presented at these meetings is super fundamental. It's actually very easy to understand, but needs to get out to the public, right? Needs to get out to people who can really benefit. The population sort of at large, but specifically people like myself who live with a type of either autoimmune arthritis, osteoarthritis, or some other type of physical challenge or disability. If you look at how people like me, one of the key takeaways from the workshop, Kel, was, are these things being used? Well, patients think they should be, used a lot, and that there should be sort of quality indicators specifically as they relate to knee replacements and hip replacements, whereas clinicians were more focused on their physical exam.
Mm.
So you can see the tension there between what patients want and what clinicians are doing or want to do. And we need to bring those two things together. And Dr. Westby has, I think, something she said just seared into my brain. That mismatch, that tension is a huge educational opportunity. and is really the focus of her research program and has been for a number of years. So she talked about the importance of bringing these performance-based tests or measures together with patient-reported outcome measures or PROMs. She wants to marry those acronyms. I don't quite know what we'd get there from an alphabetic perspective, but we're not going to go there. We'll just say that those two things need to come together to solve the riddle of function, ability, motivation, all of the things that go towards people being happier in their bodies if they're living with something called arthritis.
You you mentioned that at the end of this episode, there will be a link to an interview with Dr.
Yeah.
Westby in a special episode of Arthritis at Home that we called Patient Experiences and Quality of Care during Rehabilitation After Total Joint Replacement Surgery. We're also going to include a couple of episodes from Arthritis at Home that look closely at the total joint replacement experience that I know is close to your heart. So the next and final highlight that we're going to share today, Cheryl, is a session, a Meet the Panel session that addressed health disparities and other challenges to clinical trial design in rheumatology. Representation in arthritis research is a very important topic for us here at ACE, and we follow and report on it regularly. At this session, they explored clinical trial design with a focus on improving that representation. And by that, they meant, diversity, equity, and inclusion in enrollment. It featured Dr. Sarah Sheik from the professor of medicine and division of rheumatology from the University of North Carolina. And once again, a spotlight on Canada, go Canada. Also members of this panel were Glenn Hazelwood, an associate professor of medicine at the University of Calgary and a close collaborator of ACE, as well as one of our strongest partners over the years, and that's Dr. Janet Pope, professor of medicine in the division of rheumatology at the University of Western Ontario. Cheryl, what were some of the key points from this session?
Well, again, sort of where we discussed a bit earlier on in this episode, Kelly, in trial design, if you don't have diverse populations, meaning people of all colors of the rainbow, all cultural backgrounds, socioeconomic status, life experience, disease experience, you are not going to be able to have takeaways or make generalized recommendations for anyone other than white people, because they're the people that are typically in studies, unless they're done in other countries. And then you're comparing, those cultures and those race backgrounds to those that are done typically in big phase 1, 2, 3 studies for drugs. Historically, we've had, there's a colonial mentality to business, to developing products, right? We haven't enjoyed that. This is changing, to be sure. Trials of the past, if you were to look at, through research journals, Kel, one of the most consistent things you read, and especially in drug trials, but also non-drug trials, is study population lack diversity. You read it over and over and over again. So the question is, how do you change that? And you change it in the same way, in some ways, as you do with who gets through the clinic door, right? You start seeing people who are first and foremost the clinical trialists, who are people of color, who are representing diversity. So if you, I actually wrote about this for J Room years ago on the lack of diversity in clinical trials. And one of the big barriers for people of different racial and cultural backgrounds is a lack of trust in who's asking you to participate, because they don't see themselves in those settings. They're not mirrored back. So you're sitting, let's say you're a Hispanic person, and you're sitting in front of someone like me who's asking you to participate in a trial, you're less likely to do so. That's what the evidence says. So we need to diversify. And that's what's so exciting about going to the American College of Rheumatology meeting. And here in our own Canadian Rheumatology Association, we're more and more seeing diversity. So that is a significant challenge, and one you're not going to hear a lot of rheumatologists or drug development people talk about. So we have to start addressing systemically why trial design has lacked diversity. So getting to people who are underserved and should be in trials is super difficult. How do we do that should be the question we're asking our collective selves. I think Dr. Pope highlighted something super important, and that's to revise really outdated exclusion criteria. So to get into a study, there's a list of things you need to have basically, and a list of things you can't have in order to walk through the clinical trial door. And it's the things you can't have that is outdated, and probably some of those exist in the inclusion criteria list as well. And one of them is just having too many items in the exclusion criteria list. And Dr. Pope is one of the most respected expert trialists in the world. So if you're on X or Blue Sky or some other social media platform, follow Dr. Pope. You'll learn a lot just by doing that. And she highlighted some of the things I've already spoken about, and that's we have to make demands. And I think she used the right word, and that's a quote from her. You have to demand from your research institution, from government agencies, from pharmaceutical companies who are overseeing these trials, Kel. The trials are built for exclusion of people that are in most need, in greater need, let's say. Not that those who are going into the trials now aren't in need, it's that there are a lot of people who can't get through the door who are in need as well. So I think that's kind of what the presenters focused on. And again, some things new to us, but I think what's important from these speakers, Dr. Sheikh and Dr. Pope, was the amplification of it, was the top tier profile that these things are being given at these meetings is going to be fundamental to change.
And a reminder to our audience, if they want to learn more, Cheryl, about participating in research, they're going to have links to some ACE resources. And it's important, I think, for our audience to keep in mind that participation is not just limited to, clinical trials, but you can participate by answering questionnaires and surveys. And certainly ACE is reliant on our members and subscribers to participate in our national surveys. And we thank everyone who has participated in them, and we hope that others who haven't will. Really important for us to get a survey and a grasp of what the issues and experiences are from our audience, but also participating in individual or group interviews with researchers and involvement with research decision-making on advisory boards or councils, which I know personally you've done, Cheryl, and we have a number of patients across Canada who are actively doing that as well. So there are other ways to participate. and there'll be links for people to learn more about that at the end of this episode.
Yeah, I just want to interject. One of the great links that we'll provide is to Arthritis Research Canada, who is our scientific partner, Dr. Glenn Hazelwood, and a number of researchers whom we've mentioned during this episode are our senior scientists there, clinical research scientists there, and they have an arthritis patient advisory board, which is a fantastic model for inclusion of input, of participation, of expertise baked within their institutional model. And I think this is what is so critical to seeing change. You have to have that at government, you have to have that in pharmaceutical worlds, you have to have that in academic research institutions, or things will not change. They will not change without those things.
Well, thank you, Cheryl, for taking the time and walking us through some of the highlights from this past week's annual meeting of the American College of Rheumatology. We want people to click on those Joint Health Expresses that go through the 4 days of the conference and 4 days of highlights. Looking forward to getting comments from our audience and thanking you for joining us today. We look forward to seeing you again on another episode of Arthritis at Home. Thanks, Cheryl.
Thanks. Take care, everyone.
Bye-bye.